So now I welcome Dr. Suresh Kumar Gupta. He is currently an HOD of the Government Medical College Chandigarh, and he will be talking about GDD in a refractory GDD glaucoma in post-keratoplasty. And we know post-keratoplasty, there are multiple reasons for developing glaucoma. Most of the cases have a 360 degrees INECA also, and there is some tricky in doing these surgeries. So I welcome sir once again. Go ahead with the presentation. Yes.
Thank you, Dr. Faisal. Good morning, all. And at the outset, I am grateful to Dr. Faisal for including me in this program. And I'll be discussing glaucoma drainage devices in refractory post-keratoplasty glaucoma. No financial disclosure. Any rise in intraocular pressure after penetrating keratoplasty with or without associated optic nerve head changes or visual field changes constitute post-keratoplasty glaucoma, and its incidence varies from 90 to 31% in early postoperative period, increasing to 18 to 35% in late postoperative period. It's quite prevalent and it has become second leading cause of graft failure. And risk factors for having this post-penetrating keratoplasty glaucoma is having any form of pre-existing glaucoma, maybe POAG, PACG, or any rise in pressure because of either perforated corneal ulcer and adherent glaucoma, ICE syndrome, or patient has undergone keratoplasty in the past, or patient has undergone keratoplasty for pseudophakic corneal edema, or cataract surgery is done as part of keratoplasty, or patients having trauma. All these eyes are more predisposed to have post-penetrating keratoplasty glaucoma. So the mechanism can be open angle closure, but in most of patients it's combined mechanism. And it's a diagnostic challenge, especially in eyes with opaque cornea. When measurement of intraocular pressure becomes difficult, optic nerve assessment as well as visual field analysis is difficult, and angle assessment also becomes a little difficult. So IOP assessment, especially in eyes with showing irregular Myers on Goldman applanation tonometer, you can go for tonopen or pneumatic applanation tonometer, or currently DCT can also be useful in these eyes having more corneal thickness. Angle assessment, if cornea is opaque, you go for UBM. UBM is useful in assessing the angle and in establishing the mechanism of glaucoma, and it's also useful in eyes when we are planning glaucoma drainage device, because if we find a large synechiae in one particular quadrant, don't put device in that, go to another quadrant. Or it can also be used to look at the tube after postoperatively if cornea is opaque. So though UBM scores over anterior segment OCT, but it has the advantage of being non-contact and can be useful in certain cases. Optic disc evaluation is another issue in especially with opaque corneas, and then ultrasonography can help in evaluating the optic nerve head damage. So in one of our departmental study which has been sent for publication, we correlated. We had two groups, in one with clear media where disc was seen with 90D lens, and in opaque cornea we did ultrasonography, and we found very strong correlations in disc with cup disc ratio more than 0.4. So management is another challenge in managing in these patients. So medical management is given till patient is waiting for surgical procedure, and we avoid myotics and prostaglandins in these patients. Laser iridoplasty or laser iridotomy can be useful in patients having significant secondary angle closure. In surgical management, trabecular colectomy with mitomycin C was found to be useful, but with the advent of glaucoma drainage devices, they have become mainstay of surgical management of these patients. One of our departmental study, though small and preliminary study, but it found trabeculectomy with mitomycin C useful in these patients. And now with glaucoma drainage devices, in literature we have found that the success rate is much better with GDD as compared to trabeculectomy with mitomycin C. But the main area of concern in these devices is corneal endothelium and endothelial decompensation. So the list of complication, Professor Sushmita Kaushik will be dealing with them. In detail, I will be just focusing on graft failure. So graft failure has been found to the tune of 10 to 31% in these eyes. And one study found that there is 60% reduction of endothelial cells within 2 years after the surgery, which is very, very, I mean, serious issue. So one study found that distance between tube tip and endothelium, it was the most important risk factor for damaging the endothelium. And logically, if we keep the tip of the tube away from the endothelium, it will be protective for the endothelium. So one of our departmental study which has been accepted for publication in Indian Journal of Ophthalmology, it's a retrospective case series of 66 patients in which 43 patients underwent ciliary sulcus implantation of tube as compared to 24 patients in anterior chamber implantation, and we found that intraocular pressure was similarly controlled in both the groups, but the corneal decompensation was significantly higher in anterior chamber group. So we advocated use of tube in the sulcus wherever possible, like patient having aphakia or pseudophakia, especially in post-penetrating keratoplasty glaucoma. So a small video showing AGV implantation in post-penetrating keratoplasty glaucoma. So I prefer AGV or valvular device in these patients because you have good control of IOP in the immediate postoperative period. In non-valvular devices, the IOP has to be controlled with medication for at least 6 to 8 weeks after the surgery. So doing priming has to be very gentle in valvular device, otherwise valve will be damaged. So then after priming, it's put in the pocket created for the implant, and then it's fixed to the underlying sclera with 9O or 10O nylon suture. So paracentesis is done for anterior chamber manipulation for putting viscoelastic, and then it's being fixed to the underlying sclera. So since it's a non-valvular device, we don't occlude the lumen, but tube, I always anchor to the underlying sclera. This keeps the tube in place. So viscoelastic is being put. Now a track is being created. Since this is pseudophakic eye, I'll put the implant in the sulcus. You go 2 millimeter behind the limbus and then create a track, and you see the needle within the anterior chamber. And now tube is being cut around 3 millimeters. Since it's going into the sulcus, so it has to be little longer. So then rest of the surgery is same as we do in other cases. So few of our patient in the postoperative period, tube in the sulcus. So concluding my talk, post-penetrating keratoplasty glaucoma is fairly common problem, and it poses several diagnostic and management challenges to the ophthalmologist. Glaucoma drainage devices, they offer good control of intraocular pressure in these patients, though endothelial decomposition is one of the major issue. So tube in the sulcus in eyes wherever possible, like in pseudophakic eyes, will protect corneal endothelium. Specular microscopy is important in postoperative period. You pick up damage to the endothelium, then change. If tube has been put in anterior chamber, you can shift in to the sulcus later on. And these patients, they need aggressive and prompt surgical management to save vision. Thank you.